All right. Aloha, everyone. Thank you so much for coming. And thanks to the many of you that are on Zoom. We've got about 28 people right now. So I'm Lewin Hulam. I'm the Associate Dean for Academic Affairs here at the John A. Burns School of Medicine. And I wanted to thank all of you for taking time out. And several of you joined yesterday as well, either in person at the HMA or via Zoom. But we're really, really happy to be able to help host this amazing panel. And so I'm going to let introductions and other things happen, but just really wanted to welcome you and thank Dr. Kelly Withy, who is with our medical school. And she helps lead all physician workforce efforts. And that's how we're able to actually get Dr. Rosenbloom here, but really to the Hawaii Health Provider Task Force, who has done amazing, amazing advocacy work. And then Dr. Kaohimanu Dang, who has been working hard and having many conversations with Dr. Rosenbloom over the last several months. So I will turn it over to Dr. Lewin, I believe. Okay. All right, thank you.
Aloha, everybody, and welcome to this event. We're here tonight to discuss together a very controversial topic, the topic of prior authorization, which has become, a source of concern for doctors and hospitals, for other healthcare providers. Recently, it's become a concern for patients. And as we all suffered through the fact that there was a tragic murder of Brian Thompson, it's sort of an expression of national angst that comes out of this issue, and some of the reaction to that was disturbing in terms of people who were just angry and wanted to almost support that horrible action. I have the belief here, I'm Jack Lewin, the administrator of SHPTA, a former director of health. I have a belief that we in Hawaii have a kind of unique opportunity to come together as a smaller state where we all know each other, and forge some kind of consensus around how to deal with this issue in a constructive way, but in a real way, in a way that actually takes the burden off the shoulders of all the participants. I think we tend to forget that the health insurers themselves feel very burdened by it, even though they're the perpetrators of the process in some ways. And we all understand none of us wants to support the provision of medical care that's not necessary or appropriate or unneeded or perhaps even dangerous. None of us supports that, but we now have built a process somehow through this whole evolution of what started with prior authorization to something that has become a serious concern that has to be addressed. We're very, very fortunate. Thank you, by the way, Dean Shoemaker, for having us be here. I see our previous dean is here with us today, and we have the president of the Hawaii Medical Association and the executive director, and a lot of folks here who have real standing on this issue, and who want to work together to try to solve it. So tonight, I hope this panel can offer that. But we're really honored to have David Rosenbloom with us. He was there in the room when this process was first kind of created and started, way back when, and so he's got a very historic perspective on the topic that we think is really going to be useful for all the rest of us as we kind of consider together what is important to us, each of us, that needs to happen. What needs to be changed? What do we want to see that's going to be different in the future around this, and have some consensus, and perhaps I'd like to say that clarity is power, and I think it would be great for us to achieve some kind of clarity tonight about what we in Hawaii might do to constructively move beyond the concerns we all have and share together. I think it would be great for those of you who are virtually watching and those of you who are here in the room to hear briefly a summary again from David Rosenbloom about what he said last night, and just to kind of hit the key points. And then I'm going to be here as the moderator with this terrific panel. We have Drs. Okamoto, we have Dr. Akiona, and we have Dr. Tenn Salle joining us. These are all really people of standing who I have great respect for. So I think we have a terrific panel. And I'm delighted to see one of our leaders from the legislature, Representative Teresa Mato, here with us tonight, because she's an inspiring person for us to work with on the administration side of trying to solve problems. So thank you so much for being here. And without further ado, David, we'll begin with you. Thank you.
Thank you very much. Of course, I have to remember what I said last night. But thank you again for inviting me. And thanks to the folks in the task force who worked so hard on this issue and been so gracious to me and my wife, Alice Richmond, who's with me tonight, but Dr. Akiona and Dr. Kreutzberg and Liz Rance and David Issei, and of course, Kelly from the medical school, who's been particularly helpful to me, and I thank her, and Liz Ignacio and Mark Alexander from the Hawaii Medical Association, and Jack Lewin. It is a sense of how people are coming together around this issue from all over the state. Thank you, Representative, for being here. I confess that I was in the room when it happened at the Health Data Institute in the mid-1980s. But what we did was really very different from what you have now. And what we did as a result of discovering, really for the first time, how variable medical care was around the country and within the same city. Medical costs were going up. Our clients were the major insurance companies and the biggest employers in the country. And they wanted to be able to show their customers they were doing something about high cost. And so, the technology was becoming available to actually build these systems. And so we created prior certification systems and large case management programs, large case being $50,000 in those days. But it was a process of negotiation and discussion. We almost never turn somebody down. The design was to defer to the treating physicians. And that is just no longer the case. And that's sort of why I got off the wagon and in guilt have come to be talking and writing about this issue. It's always very important to take note of and be very careful about the ecosystem in which the health system operates. Because if we don't have a healthy ecosystem, we can't have good population health. And that health ecosystem's got to have balance. You've got to have payers who can actually be stable and financially secure. You've got to have doctors and providers who are going to come back the next shift. The assets of the health ecosystem walk out every night. And so you've got to have providers, you've got to have hospitals that have the resources that they need, and you've got to have patients who have access and confidence in the system. And if you don't have that balance in a healthy ecosystem, that you really can't function very well. And it's how prior authorization affects that health ecosystem that I think is probably what I want to learn about, and I think what we all want to talk about in the coming days. As I think about this, and I said this last night, the one basic fact that drives a lot of my thinking about all of this is that in traditional Medicare, there is no prior authorization. None, except maybe for a wheelchair. And yet traditional Medicare is now cheaper for the federal government than the Medicare Advantage programs, all of which have prior authorization. And that's sort of a driving factor. I think that prior authorizations become basic to the business model of particularly the Medicare Advantage insurers. By spending less, they free up cash for their other activities, for profit, for extra benefits, dental care, vision care, that kind of thing. They do reduce their spending. They keep doctors busy and reduce their productivity for billing and other things. And they create a virtuous cycle of their profits doing all of this. But having said that, I don't think prior authorization works for anybody, including them, over the medium and short term. There's very little evidence in the published literature, excuse me. There's really very little evidence in the published literature that prior authorization is effective. All the studies come out with an ambiguous finding. The docs argue that it leads to additional utilization, and I think the theory does too. Total health expenditures equal the units of service provided to patients and the prices we pay for those units of service. That's total spending. And the only way to affect total spending is to have control over both utilization and price. Prior authorization deals a little bit with utilization, but not at all with price. And so over the medium term, at least, it really has no impact on total spending. There's no consistency among the insurance companies. They apply prior authorization at different rates. Some in Humana, you can expect to see 3 prior authorization requests a year. Some other carriers, it's 1. They differ in what they have prior authorization about. They differ in their response rates. Humana turns down 10% of its requests for authorization. Kaiser Permanente turns down 0.5%. So there's great variety all over on all of this. It's clear from doctors' view of all of this that prior authorization contributes to burnout. And there's lots of evidence, both published and anecdotal by the doctors, that prior authorization can and does often harm patients, up to, in rare cases, death, but often inconvenience, higher expense, delayed effective treatment. So my suggestion has been that we do away with prior authorization and see what happens. Study it seriously. Look at what happens to cost. Look at what happens to utilization. Look at what happens to patient outcomes, all of which I think are made worse by prior authorization. Let's see what would happen if we didn't have it. Do I think that's going to happen? No. But, Hawaii has these opportunities. So since I don't really think that it's going to happen, let me just say a little bit about what I think carriers are doing, what the feds are doing, what states around the country are doing. And then I really want to shut up because I think that I've come to learn and you've come to have an active discussion. So carriers are responding to the noise and to the pressure. Many of them are reducing the numbers of prior authorizations that they're requiring. United has announced a 20% cut. Cigna, 25% cut, Humana, a cut. So they're reducing the numbers. They're speeding as fast as they can to introduce artificial intelligence, which may make things much worse. The denial rates for United Health post-acute care doubled after they put in an AI review system. So, but they're racing to automate and put in AI. The feds published a major rule last year that'll go into effect in 26 and 27 that basically creates a new framework. Does not deal with the substance, but creates a framework for prior authorization in which there'll be common interfaces for the physicians and the insurance companies and patients even. And we'll see how that goes, but that's coming in over the course of the next couple of years. And at the state level, the American Medical Association has done a very good job of both leading on this issue and in summarizing what's going on in every state. And so there's a big chart that they publish every year. Unfortunately, the line for Hawaii is largely empty. But what it does show and gives you the guidance of the kinds of policy choices that are available to be made. Last year and the year before, something like 13 state legislatures passed significant legislation affecting some of or all of the prior authorization issues. The prior authorizations, like, is there a single form that people can use? What's the response time? Most of the states are now setting up about 24 to 48 hours for an urgent request, 2 or 3 days for a business request, a routine request. That's sort of what's going on around the country. How long does the prior authorization last? If you have a chronic disease, once you get prior authorized, is that it? Till your chronic disease goes away, which it doesn't. So how long what's the duration? What happens to denials? Can you retrospectively deny something after you've agreed to it? What kind of reporting is required? What are the criteria being used? And the state legislatures are passing different rules with respect to what criteria must be used for prior authorization programs. How transparent? They're passing rules on reporting and transparency and publishing on their websites. They're passing laws about how qualified the reviewers must be, and whether there should be peer-to-peer reviews and what those look like, and whether there should be exemptions. So those are the kinds of policy choices that will be available to you and are being taken up by states around the country. So there are some ideas that haven't yet been passed into law, and I'll leave those with you as well. In Massachusetts, the legislation that's pending would call for an independent commission to actually run all of the prior authorization programs. And there would be a single set of clinical criteria that all of the carriers would have to use in their programs. In other states, there's some proposals that carriers would have to pay the doctors to provide the information that they need for complex prior authorizations rather than just the routines. Some carriers would be fined in other states if their turnover rates, if they've denied it and then accepted it, if those rates are too high, the legislation proposed would fine the carriers, saying you shouldn't have done them in the first place. And so if you've got this bad ratio, we're going to fine you. And then finally, an idea which I would propose in some of the states is looking at is to set a glide path to, over time, reduce prior authorization based on the experience that you have, so that if things are very, very frequently approved, let's just stop doing that and whittle down over time to the most necessary things. You're going to need a lot of data in Ohio. Largely the data that they're already collecting in other states is what you're going to need in order to pass legislation here. And so look to what other states are doing, collect that data now so that you can have it for your planning processes. So I thank you very much for inviting us out. And now let me sit down and listen and learn. Thank you very much.
See, is it on there, Mark? Thank you. I think it is now. Can you hear me?
You have to turn your microphone.
After you do it? Yeah. Excellent. I'm very technically, enabled. It's amazing. So let me start with a discussion with each of the panelists. And let me start with Dr. Gary Okamoto, because, Gary and I have known each other for a lot of years, a practicing doctor here. He's been through, this is a place you know and love. currently the Chief Medical Officer for AlohaCare. And I would say that in our state, of the three homegrown larger insurers, we have HMSA. Unfortunately, they couldn't be here with us tonight. Kaiser Permanente and AlohaCare. And we have other insurers as well, but those are the three that we would say are the homegrown companies. So Gary, thank you for the courage of being here with us tonight. And, would you tell us, I'd like to ask each of you in your panel response, one question that actually David raised last night, which is, what would you like to see happen? What would you like to see happen here? And it could be simple, it could be complex, but what would you most like to see happen as, what we're going to do next?
Okay,
Thank you.
No, thank you very much for asking that provocative question. I'm not sure whether I'm going to answer it the way that people would understand it. But I do want to thank Professor Rosenbloom. I was very engaged and engrossed in your presentation last evening, and I really took to heart a lot of the things that you recommended that we think about doing as we try to solve these issues in a way that doesn't add to the complicated, complex mess that we currently have. But there was very little that I could ever disagree with you on. So thank you for that experience. I would say, I'm just looking at the hierarchy of different things that I might want. I would say data probably, because I don't think we can intelligently, rationally plan to take action unless we know what the problem is. And to do that, we just need the data. Now, I know that's something that you, Dr. Lewin, has championed and has made very important in the AHEAD grant, which I'm sure you're going to discuss more. But I do feel that way, that we need to have data.
Mm-hmm. Okay. Well, thank you, Gary. Dr. Akiona? Yeah, so Keahi, I think we just a little background for you. This is a physician who lives on the Big Island, works very hard, takes care of a lot of people, and then actually journeys the impossible journey to Molokai to try to produce and provide care for people there in an environment that's really, really in distress in terms of workforce. So, you're a champion to a lot of us. And what would you like to see happen?
Hey guys. So first I'd like to say sorry, because on behalf, I'm actually pinch hitting for Dr. Esther Smith, my colleague from Kona, who's a fabulous family physician, but her grandson arrived early. So I agreed to step in and kind of talk to you guys on behalf of practicing neighbor island, kind of more rural physicians, actively in the middle of everything. And so I like to say that we have a unique opportunity, and this is kind of my ask to my colleagues and to everybody else is that it's really important, I think, that we be a part of the conversation. A lot of us are living in a perception gap. And this is during the pandemic, I talked about this kind of a lot. There's a perception gap between what we think is happening and then what's really happening. And I mean, I'm from Honolulu, so then I know that there's a difference between what we feel is happening here and then what's actually happening on the neighbor islands. It's kind of similar when you look at our professional stuff. So what we've been trained to do and then what we're allowed to do. And I think that's been widening over time. And so prior authorization for us, for me, is important because it's a really key proxy that we can all kind of gather around and have meaningful conversations. It's a key proxy to what's changing. You know, there's a few first-year medical students here. It's what's changed professionally and for the relationship building. So, you know, when we're kind of casting your physician in like a, you know, kind of a light of distrust where we have to double check what they're asking for. Is it really needed? Is it really unnecessary? It interferes with that relationship building process, but it also interferes with your ability to practice. And, you know, it's not exactly what we had hoped. I think when you asked what would we need or what would I ask, I actually had written down a commitment to better data collection and stewardship. Today we're listening, I was listening to like, you know, voting being the one thing, like this is the one key right to preserve all rights. And for me, data is kind of key to preserving everything else. And that was my ask to the medical school and to like, you know, OHA, all the different organizations that I've ever talked to about what we're doing in Molokai and the Big Island. It's can you help me be a better steward of the data? Because there's really meaningful stories happening. The physicians are, you have a unique role because you hear anecdotally, you see people in their most vulnerable moments, you see the effects. So in your office, you actually see what happens. And over time, my mentor just retired, and he was saying, 800 babies served, 300 plus residents. Over time, you have a really neat data set that's unique to you, but also really important for everybody else to hear about. And so I think, from the professional side, but also to the community and then to the people around us, I think it's important to find ways for us to be better stewards of the data, but then also find constructive ways like this to share it and to talk about it and constructively. That would be my question.
Perfect. Thank you. Thank you, Kahi. And then, our next panelist, Dr. Tenn, she's another champion from my point of view, a highly respected physician and working at Queens with a long history of really contribution to improving health and medical care here in Hawaii. So Nadine, what would you like to see from that kind of a big city urban hospital practice as a next step, or what would you like to see solved?
I think I'd approach this, let me back up. I
Sure.
agree with everything that everyone is saying, absolutely. But I think that prior authorization, well, this is our discussion and why we're here and where we've advanced with this discussion, because if you think back about 2-3 years ago, we were arguing that it was even a problem. So just the fact that we've moved the discussion forward, that there's acknowledgement, not just on the provider side, but even on the insurance side, that maybe it doesn't fit what we're doing right now in our present healthcare practicing environment, is a huge move forward. But in many ways, while we are discussing prior authorization, it ultimately represents an example of the administrative burden that has been placed on providers. The administrative burden represents both time and finance that has been pushed away from the insurer, and the insurers are not necessarily bad, but it has been placed on the provider side. And of course, it is more heavily felt on private practitioners and people in the rural communities. My point there is, in order to do the steps that logistically take to have a prior authorization completed, cost provider time, medical assistant time, and all of that translates not only to additional hours outside the 15 minutes or 20 minutes that were allotted to see a patient, and the cost stays there. So even though theoretically the point of it is to lower the total cost of care, the providers, whether they sit in private practice or whether they sit in the hospital, don't get to, they get no benefit from this. Then the flip side to it, it was put in place historically to make sure that we were delivering the highest level of care, no unnecessary procedures, and that there'd be a lowering of the total cost of care. But to your point earlier, and I think you've alluded to this, that's why we were at the point of having legislation in the Senate right now, as well as the House, is it actually doing that? So we're having like a philosophical discussion when we don't even have the data. So I start with what was said before. I think just the way our minds predominantly, not everyone in the room here are physicians, but we tend to be science-based. We can neither understand the problem nor come up with a solution until data is available for us to look at it. Once the data is available, yes, we can come up with different operational ideas, but until we agree on what is the priority around prior authorization, and will anything we do actually get us there, we're going to be speaking in circles. Yeah. So the thing that I would hope that we get out of this meeting is, one, a general consensus that data and transparency of data is important, and a willingness for the payers to be at the table with us, to give us more clarity of exactly what they're trying to achieve and how we can measure it together so that we're actually doing something. Otherwise, if it's a waste of time, to your point, maybe we should get rid of it.
Well, that's beautifully said. I think all three of you. I would just say as we go at the next phase of this conversation. So for the audience out there, we do have two bills that have made it amazingly far. They've gone all the way through the House of Representatives and all the way through the Senate, through all the committees, and they're now going to conference committee. And the bills do a couple things. One is reporting to the State Health Planning and Development Agency, which I administer. We collect already all the claims data from all the insurers, so it's not like something totally shocking and new for us. But in this case, this is a whole different kind of set of data, but that's going to come in if these bills pass. And then we'll know where we are, and we'll have a much better sense of what we ought to do, given that. The second piece of it is, some people think it's a kind of a laughable assumption, but we're all going to get together as doctors and hospitals and clinicians, insurers, and consumers and purchasers of health care as a working group. We figured out who the assigned people would be that we're going to bring on that working group to represent the whole health sector, and then sit down together in this state to attempt what Massachusetts aspires to do with their commission in one sense, which is agree on the peer-reviewed, professionally determined guidelines, standards, and appropriate use criteria that have been painstakingly developed into minutia and detail. So you could have heart failure, but you could have 50 other kinds of heart failure, frankly, and you could have 50 other kinds of heart failure with renal failure and with diabetes and with some genetic disorder. And the people stand back and say, well, then you're going to need so many experts and consultants to be able to do this. But the reality is, no, we have the expertise right here in our state among our physicians and hospitals and insurers and consumers like EUTF, our biggest employer. They have to look at this too. So among us, we have what we need to agree. And if we did agree, the assumption in that second part of those bills is that we could then automate the process so that before the patient leaves the doctor's office, the determination is made. The physician, she will or he will understand that he or she forgot to add some elements that have to be included because they'll be informed that way. And meanwhile, before you even get admitted to the hospital, the whole thing will be determined then. So this would be one way of solving the problem. It might not be enough. And so I'd like to start by just asking David, is that enough? I mean, you've said we ought to go further, but is that a step we ought to take? And what do you think about it, panel?
Well, far be it for me to say data is not important, because it is. And it enables you to ask questions which you can't ask now. You said that you get the claims data already. And if you get the transaction data for prior authorizations in the state, you will have at your hands the capacity not only to know that prior authorization was required in this diagnosis or this procedure, and it was approved this many times and appealed that many times, but you will also have in your hands the ability to, on at least a sample basis, understand what happened to the patients. What is the subsequent claims experience of a subset of patients whose prior authorizations were denied? You will have that information in your hands. Now, looking at it takes some work, but it'll all be there. And I think that's the kind of background information which you will be able to bring to the table of people sitting around. And all of us are now accustomed to going to tables where all the stakeholders have been invited. It is now a standard procedure. If the stakeholders come to defend their turf, then you're not going to have a great result. If, on the other hand, the stakeholders come with an understanding that they're going to be learning new information about their own activities, then I think you've got a better shot at developing some consensus. If the stakeholders come and realize that that at the end of the day, what the group says is going to hold, not if we don't like what we're going to get, we're going to go directly to our friends in the legislature and forget about it. If they have some sense that it's going to hold, then they really do have an incentive to come to consensus. And so I think that the framework that you set for these discussions will be material in terms of the outcome.
Thank you. Yeah, please, Nadine.
Just a very quick comment, maybe almost to take back from our original discussion, add something more to my wish list and then comment. I think you're correct. You know, data, we got to be careful what we wish for. You can be flooded by data. And it will take, even if the bill goes through, it'll take several years for us to sort of really wrap around the data to be able to filter it back to the community to make it effective. And if you want to do it in half the time, that's fine. I bring back to something that we brought up yesterday. I think I asked you the question, or it was actually put up as one of the questions from the audience. The reality is that our insurers have shared, particularly HMSA, that 90% of their prior authorizations are approved. So I would argue, even if a bill is put through, that we should not start with 100% of the data. We should start with that 10% and begin with a conversation of moving forward from there. What are the high costs? What are the ones that typically require, that are denied, that we need to educate on why people are ordering or maybe not following in the community, and that collectively we focus there. And we probably get further ahead in 3 years, as opposed to, again, just completely starting with the data that can be a data dump. And
Yeah, I think that's right. We need to take the most, those codes and claims and diagnoses that are the most, that'll make a difference and are the most frustrating. So, I mean, we can move with those, and that's what part of we have to do is go down the list of from highest priority of frustration to lower priority of frustration. But we are going to do that. But what else do we need to consider?
I think on behalf of at least the independent guys, I do have to say how urgent things are, though. And I think of all of the times I've had conversations with colleagues in the corridors or, the support, they're really saying we have no more time for this, like, gather around and let's talk about the problems again, because a lot of them have lost their careers, they've lost years of life, they've lost too many patients. And so, like, I think I've talked to the few people out there already, and it's like, I was fortunate enough that when I got opened the practice or, set up shop in Molokai, that AlohaCare actually reached out to me and asked, how can we make this a little bit easier? They recognized that there was a severe disruption in care. And so I was concerned because I knew that it was going to appear like we were overutilizing at first because we were trying to get people back on track. So it would feel like a kind of a weird moment where we were overutilizing, but it was to get people caught up. And they understood that. So they tried to lower the barriers for me, because I was trying to explain to them, like, every patient, I was taking care of homeless people for a while too. And every 15 minutes I spent face-to-face was like 4 hours of time behind the scenes, trying to get them to the right surgeons and to the right specialists. And then my specialists were calling me and saying, this is ridiculous because now we're having to prior auth the medication. And, you're doing the right thing. You're getting them to the endocrinologist, and I still need a prior. And so I was able to have a conversation. But I think on behalf of the providers, I would be remiss to not say it's pretty urgent, like it's dire. We're losing a lot more of our colleagues. A lot less of us are covering a lot more because people are passing away, retiring, moving on, or just burning out. And so like every time I'm talking about data, because I tell people it's really important, I'm also keeping in mind that a lot of my friends no longer want to talk about this stuff anymore. They don't feel like they can because they feel like the system has failed them. So, you know, when I'm saying like data stewardship, let's be better steward. I think have to say I have to speak to the urgency of it, that this has to change soon. The system is
That's
not
great.
being
Yeah,
kind.
we have to do something. Gary, what has dawned on you while you're listening to everybody else that you forgot to say in your first set of remarks?
Well, I think a number of things. First of all, in terms of talking about the Echo Health system, healthcare system that Professor Rosenbloom referred to earlier, AlohaCare is a local 501c4, and any of its margins go back into supporting community activities. It was founded by community health centers. It's the supermajority on the board are community health center executives. We have a very close association with them. Half of our membership has primary care assigned to and attributed to community health centers. So I do recognize the sense of urgency that they bring to me and others on my staff, that we have to do something about this fast, but we need to do it in a collaborative fashion. Doing it unilaterally in a somewhat paternalistic way is not the process that we want to encourage at all. Just a couple, two things that have come to my mind. One that we haven't really talked about that really deserves attention maybe later on in the year is pharmacy. Because at every physician liaison committee or group meeting that I've had over the past half year on all the neighbor islands and Oahu, every physician really translates the issue of prioritization away from the usual the MRI scan, the exotic imaging studies for the heart and so forth, to medications and how upset they are about the step therapy. Having said that, we all are aware of the expensive drugs, and there has to be some way that we go about doing this in a rational way that doesn't compromise good patient care and patient safety. At the same time, looks at cost in a serious way. Now, this is just a quick op-ed because Dean Shoemaker is here. I think the medical school, given its all-pervasive influence on the practice of medicine in Hawaii, really needs to, my opinion, have devoted research and teaching in this whole area by faculty, by fellows, and that what we're talking about this evening needs to be integrated into the way that the graduates of the medical school and its faculty think about how they're approaching this issue of balancing the health of a population, the individual care experience, and cost.
And I just imagined particularly for Representative Amato, who's here with us tonight, that we're talking in the legislature about whether we want to cover biomarkers, we want to cover genetic testing, we want to cover some other of those technologies. We can't approach the new biologic drugs and the genetic related therapeutics without having super sophistication in terms of positioning patients for $1 million drug. We really literally have to begin to add all of that technology, which I found was embedded already in the practices on the East Coast, but not yet here. So that's all part of the complexity of what we need to face, which is in addition to what we're discussing here today. So what else is coming up for you on the panel that we haven't covered?
I'll second his. So I didn't end up staying home and going to jobs, and I went to University of Pittsburgh. And we actually did have a longitudinal business of medicine where we actually had to sit with the lawyers and kind of run through these kind of mental kind of just thought processes about bundling care. What did that mean? Like, was it better this lean model? And it was interesting because I think we really did at UPMC think we were doing the right thing. So they were very proud of their model. But a lot of the kids were coming out saying this was not a good idea. Like a lot of the things that we were doing, even if it was theoretical, was kind of cutting quality and saving money, and it was not clear where the money was going. So they were kind of connecting the dots. So I think a lot of us that are practicing now, we kind of buy into that business of medicine is not your thing. But I think I've come to see that it is. It has to be. Like we have to be aware of why the insurance company does need to, in some cases, oversee some of our recommendations. But we also have to be able to talk the economic piece, I think. And so I think that's where if we could have any say with the medical school, that business of medicine actually really does matter. You know, the survival of independent practice is going to rely on the future generation understanding what that means. And, you know, when I sit there and I have to run through my numbers, the viability of practice in Hawaii, it's, you know, if I'm not here, if we go away, then there is no talk about prior auth. There is no one to do the prior auth because there's no more physicians. So I do think that there has to be some understanding both
No
sides.
kidding. Yeah, I mean, you know, my boss, our governor, Governor Green, I'm kindred spirit, and we talk often about what are we going to do? What's the future going to be here? What do we have to really? What should we be thinking big picture to really get us where we need to go? One thing, obviously, is we're not paying our healthcare professionals down the whole spectrum of healthcare professionals enough to really be comfortable here. And that's why we can't recruit people to come here. So we do really have to address the fact that we're in the highest cost place, highest cost of housing, and our healthcare wages. And ironically, if we were paying more, even down to the nurse's aide for our staff, formulaically, we'd be eligible for much more money in Medicare than we get currently. I mean, so I'm committed to getting $1 billion a year more in payment boosts for Medicare. Not the AHEAD grant. It's going to have to be around the corner through Congress. We might have to hire some people, hold our nose in terms of who the lobbyists might be, but we need to get the data and then we need to get it through Congress to get it to happen. Nadine, what are you thinking? Okay, no, your microphone. Yeah.
The mic. There's part of me that disagrees with you. And not in the sense that I disagree that Hawaii providers make comparatively on a national level much less money and deserve more. It's not that. What I disagree is I've seen these conversations go in the direction where we start with the money. But even if we were to pay the providers per unit or per patient more, if the system remains in place, we're going to be in the same place.
Totally
Does that
agree.
make sense?
Totally
So,
agree.
yes, our providers need to, our
Oh, yeah.
providers and our medical teams need to be paid more because the business model presumed a very simplistic fee-for-service transaction between the provider or the clinic team and the patient. Therefore, most of what we did was within the time frame of the visit.
Yes.
What we're discussing is that an increasing amount of what we do is before and after the patient leaves, and it's becoming like exorbitant. It's almost a second day of work by the time you're done. Yes, you could theoretically pay the individual more, but I think we have to begin with where are we presently in 2025 with regard to our health system? What is have our objectives from 1965 to now changed? One of that has changed is how much we're looking at the total cost of care, how much is inefficient in our overall system. Do you see what I mean? And
Sure.
move from there. But then now I'm
charged with
taking you
measuring
down.
that.
I know, but unfortunately, now I'm taking you down where I'm shaking up the whole
Yeah.
health system as opposed to where we are today
Yes,
with this
yes.
panel, prior authorization.
And thank you for improving and for being more eloquent than I was. I'm gonna now ask some of the questions out there from the folks listening. There's several up there that I think would be interesting. One is why is there not more support for shared computer capacities to understand what's happening better? If the carriers are not more transparent, how can providers trust them with their data? I don't think there's a question there. That was a statement. Thank you for the statement.
let me, if I could turn this on. Let me just comment briefly that if the state requires the reporting of data from all carriers under the same circumstances, then the issue of trusting the data to a certain degree goes away insofar as you've got the data.
Sure.
How you use it, and I agree with you, focusing on the use of the important stuff rather than everything. But I think that the trust of the data builds over time when a neutral party has its hands on it.
Yeah, that's good. And we have to remember that health plans are already required to report to CMS on the Medicare and Medicaid side, Medicare Advantage side. So we're not really asking them to do more than they already are forced to do by the federal government, but they don't have to. Commercial carriers are not required. And that's where a lot of the angst is. So that's a big part of this issue. So the next question.
Can be required.
They can be, but
Yeah.
they're currently not. Let's see, if it's,
Here's one for you,
yeah,
right here.
our question shifted, developing a PA policy process for AHEAD. We are certainly going to, AHEAD is trying to, create the health system of the future for Hawaii. So we will certainly, we're wide open to include whatever we think we need to innovate to get us there or to modify in terms of current policy. So yes, that can certainly be part of that. It's a 10-year grant forever. So yes, it can be included. Would everyone agree the carriers are really at the mercy of their respective PBMs, at least regarding the issues of cost for medications? Here's a question for you. I've been asked to do a PBM legislation for next year as well.
Yeah, let me just really comment on that. There's no question that when we talk about lifting prior authorization and try to apply that in the pharmacy space, we find ourselves in a far more complex situation with a far more complex economic, business model, political situation. But it absolutely needs to be addressed in a way that's rational and that does not end up in unintended harm to patients who need medication.
Okay.
I might just comment on one of the new high-priced medications. The discounts being provided to the PBMs by the makers of Ozempic and the other magic weight loss programs, their contracts, which give them rebates and discounts, prohibit the PBMs from doing utilization review of these products.
Yeah.
Well,
PBM reform is just another area that we do have to take on. Believe me, that's another area of focus. Yeah.
And I will just say that I think there's a bunch of stuff about, data and stuff like that, that's historically been an issue that because we don't really have kind of a centralized situation in this state, that there's multiple. So I think, we're not saying that the provider should be fully responsible, because I will tell you that where they can, they will push it onto us to do all the reporting, but that it has always historically been a problem. So when I ask all the, the different legal organizations to kind of help be better stewards, part of it is not accepting that there is not a way that we can have a centralized way to report data. You're right that a lot of the data should be in the EHR, and a lot of the doctors are collecting a lot of the information, but that historically it's always been hard. Not all the systems talk together, and we don't technically, I know that they do report for certain things, but Epic and all the different data, we don't really have a truly centralized data system, which is part
Well,
of the
that's
problem.
the all payer claims database goes live this summer. Thank goodness. So that is a big deal, and it really needs to be combined with the health information exchange clinical data if we really want to see the whole picture. So that we got to do that. That's an absolute necessity. So let me see. Also, I've read medical documentation on my own personal health visits that are not accurate. And if AI is involved in decisions and using these misrepresented documentation notes, then we're in real trouble. That's a statement, but it's a good one. And, you know, there's a couple questions about how can we solve the problem without the PBMs. We definitely have to take that on. It's a parallel issue. And I did want to comment that when we started with the legislation this year, folks, the health plan world was in opposition to the bills. And as of late, our largest insurer has been testifying supportively and saying we're going to be part of that work group, and we will report the data. So there has been some progress made, at least attitudinally, but there's obviously more work we all need to do. I'm searching for some other really pithy questions here. How about it is not the carriers who have the data? If it is not the carriers who have the data, how are they making decisions about PA criteria?
I think I used to actually talk to people about this because when I was helping, so we with Dr. Green and with Dr. Miskovich, we were doing a lot of the homeless medicine. So there were plans that I was able to reach out to and ask. They were easily giving us so high utilizer data. They had endless data on who was overutilizing, and so I had flipped it and I asked them, hey, would you be able to give me the non-utilizers and the underutilizers? Because they're the ones that are going to be the next to overutilize. Because the majority of us are like not taking care of ourselves until it's a disaster. And a few of them actually did. So I think that was the interesting thing was like when we're having these conversations about data, I was like, they have a lot more data than, you know, than we're being allowed to access. And when we asked the question in a way that was acceptable to them, they provided the information. So this was literally, I would like to prevent hospitalizations and, kind of catastrophic care by providing them appropriate in the moment care. Will you help me reach out to these people? And like AlohaCare did that as well. Who has not come in for a well child? Who has not come in for a well, adult visit? Let's reach out to them and ask them for care. So like, I think to be fair, they have a lot more data from the care side. And it's just a matter of crafting the conversation to, I don't know, like to have that, to allow them to answer where they don't think that we're trying to aha anybody because we're really not. We want to just, I think the ultimate goal, and I listen to all my colleagues, is just providing better care. We just want to take better care of the people. And I want to say that that's the insurer's goal too, is to be better. So.
Yeah. Well, there's a couple provocative questions there. Oh, in the audience, do we have some questions here? Yes, please. Thank you. Speak loudly if you can. Oh.
Thank you to the panel for all your remarks. It was a wonderful discussion. So we're all familiar with that quote, lies, damn lies, and statistics. And I think we live in a very cynical era, not just our patients, but the providers too. There's a lot of anger, frustration out there. So how do we go about this process and build trust that we can all believe in? Because as Dr. Akiona Dang points out, from the provider perspective, it is urgent. We're just fed up, angry, and we want to see some progress on this. So I welcome your input.
So you might want to ask, follow with that same thing. Is it realistic to think that we're all going to get together as insurers, providers, and consumers of healthcare and actually try to work something out over the next year? Is that something realistic that might really happen, or is that, kind of a little bit of humor? What do you think?
Dr. Lewin, I would hope that the AHEAD grant would be a vehicle by which those kinds of interactions can occur in a very focused, constructive, planned way. I think the legislature also has a very important role in facilitating the discussion.
Yeah.
I had a moment multiple times during the conversation with Dr. Rosenbloom in bringing him here where I was pretty done with the conversation and I don't, but we talked and I was like, what should I do? And honestly, I think it's providing as many opportunities as we can to be in the same room together. That was one of the things that came up when I was talking with Dr. Rosenbloom is, because we're angry and because we're hurt, a lot of times it's difficult to have the conversations, but the more we're in the room and we humanize both the provider, because a lot of, there might be that mentality, I've heard it from my colleagues, oh, we need to protect them against you guys. And I'm like, I've seen the people. You're not doing the right thing when you're denying my friends their stuff. But so basically, the more conversations we can have like this, like those gatherings that we're trying to have, I think certain people don't want to hear the anger, but we've taken, I don't know, but I've taken care of a lot of people where they're at their wit's end, right? So they're speaking from hurt. If you don't let them say what they need to say, we don't have a therapeutic anything. And I think to that end, sometimes I need to hear my colleagues out, even when I don't agree with them. And I don't think professionally, I totally respect them and they have every right to say all of the things that are bothering them. Once it comes out, then I think we have a much better conversation. So I think to what you've said, having as many opportunities for us to be in the same room together and to talk is probably one of the most important things for our survival. My 2 cents.
Very good.
I couldn't agree more. And it's recognizing while insurance companies are not individuals, they are. And in the end, it's amazing how personal they take the anger. So they do not take the time to allow what they may have legislated or actually put out into the community and realize that they do have to take some responsibility and be willing to hear what has resulted from it. But that being said, it's not necessarily personal on that individual. It's on to the insurer. And I mention that to echo what you say. We have to create as many venues as possible to gather, to get together, to get the insurance representatives in the room so that we can get beyond the complaint, so that they actually are engaged to, I think you made an earlier point, if they don't have skin in the game and the round table that they're sitting on, if there is no, what was the word you put? But basically, if we have no authority over them, they can nod their head and, to your point, go down the block, have another meeting, and basically do what they will. So to your point, yes, allowing our colleagues to vent, creating as many venues and opportunities to meet with our insurance colleagues, maybe starting with models. We always go after the big players. We want to have HMSA at the table and we want them to listen because wouldn't that just fix? Maybe we're going to start with our smaller providers to model out and to move forward there. But it's going to be, the expression is, this is not a sprint, this is a marathon.
I expect them all to come to the table. But as we're getting closer to wrapping up, I want to go back to David for a second. You said something provocative last night in this session that I'd like to return to. It has to do with the fact that it seems like most of the denials get reversed. And so the care is provided. So in that case, there's a huge amount of money and frustration the health insurers are going through and the providers are going through. And that seems like an enormous waste if that's true. So I think one thing that was kind of running through my head all day is, wait a minute, are we really saving money with this process? Or is this just, are we all just kind of have to, kind of change our meds and get straight here? But David, you want to comment a little bit about that, the economics of this?
Well, I don't think the economics actually work, which, and so the insurer thinks that the denial reduces their current expenditure. That many denials are overturned doesn't matter because there are so few appeals. So the real problem is the denials stick that would have been overturned, but they haven't been brought. And why haven't they been brought? Because the entire burden of bringing the appeal rests on the provider and the patient. And there's nothing in it for them. And so there is this lack of belief, lack of trust that the denial process is fair, and it isn't. But the reality is that when you bring a denial, you are likely to overturn. When you bring a challenge, you are more than likely to overturn the original result. The insurance companies count on us not to bring those appeals. And by the way, the insurance company executives are also patients. And I'll bet that their families are just as unhappy with the delays that they get as the rest of us are. And so sometimes trying to deal with them as human patients may actually get you somewhere.
Well, we have one more question here, and then we're getting close to wrap up. Yes, please.
Yes, no, and I'm naive in the business parts of, I'm naive in business parts of medicine, and this question is not meant to favor one approach over another for solving this serious problem. I know there's been some misuse of AI for prior authorizations. And Dr. Lewin, you mentioned rapid prior authorizations, and we already get claims data and outcomes data. And has anyone used that data to like train a neural net to determine a hypothetical prior authorization set of outputs and use that model and review that and use that to develop a fast thing that might be acceptable to all parties?
You just clearly described the direction we're going in, but have not yet arrived. This is very much so. We're just going live with the all-payer claims database. We're just getting ready to bring health information exchange clinical data into that process. We're working with Epic, which has 80% of our providers using one electronic health record from which we can extract a huge amount of information, putting that together, and there's where we can use AI to come to quick consensus on what's going on. So your point is really well taken, and it's really part of the path and direction we must move along.
Okay, because I know a little bit about neural nets, but not a lot about medicine. But if there's stuff that Therese tells me I should work on.
You're right on track. And I just want to remind you that just a kind of an interesting little anecdote, in 2003 or 4, I can't remember, as CEO of the California Medical Association, my general counsel and several large medical groups in California, I was the CEO of the association, 55,000 members. We discovered that among all the groups we studied, and there were a lot of plans in California. We had Aetna, Cigna, Humana, Pacific Care, HealthNet, Anthem, which was Blue Cross, and then WellPoint and morphed to Anthem. They were all there. And we discovered that for each of those plans, there was a weird pattern where every nth claim was being denied, but it was a different N for each plan. So in one plan, every 7th claim was automatically denied. For another plan, it was every 6th or 8th. Okay, and it was a stunning thing. And I got all the CEOs together for supposedly a special big dinner to say there's some huge surprise. And I knew the people at Jack Rowe flew from Aetna all the way into this fantastic dinner where I announced to them they were all going to be subject to RICO lawsuits and criminal activity. And that I assumed they didn't know this was happening in their companies, but they were all using the same software for their claims, every one of them using the same software. The only ones that weren't were the capitated models like Kaiser and Group Health. Those weren't in. They were completely not there. But the others had their mid-managers were making huge bonuses. Anyway, this turned into, they all denied it. They said terrible things. I won't repeat here. But I said to them, well, you can either cease and desist on this, or we're going to do a huge class action lawsuit. It turned into the largest class action lawsuit in the history of the United States, with 800,000 physician plaintiffs at the end. By the way, Hawaii wasn't involved in that activity, but nonetheless, the rest of the country was. For those they're paying claims, physicians got $100,000 settlement. There was billions of dollars that were claimed and so forth. So that happened in 2004. So this is not a new thing we're dealing with here, folks. It's an amazing experience. And I think that David, do you want to just say some final remarks, and then we will.
Yeah, I don't have any great wisdom for final remarks. I would comment a bit on the question about AI. In theory, these data sets could be learning devices to make more prospective decisions. Several of the states that have been looking at prior authorization reform have specifically limited by law the use of AI, saying that no denial can be made using only AI algorithms, because these AI algorithms are basically controlled by the carriers at the moment. Dr. Oz, who is now, as you know, in charge of Medicare and Medicaid, at his hearing in the Senate, he was asked about AI just a couple of weeks ago. And he said, well, here's what I think should happen. He said, I think that the insurance companies, if they want to use AI, that's just fine. But we in the government should have our own AI, and we should use our AI to check their AI. And that may be where we're going. And so at that point, the patient becomes even more of a pawn than it is now with competing AIs. So I think that we need to be very cautious. The insurance companies that have applied it have found their denial rates going up dramatically. And that's why I think we're very, very cautious about it. Thank you very much again for having me.
Yeah, so, and before we actually thank Professor Rosenbloom and Drs. Tenn, Salle, and Akiona and Okamoto for their wonderful comments and participation tonight. And we should do that. And for those who made this possible here at JABSOM, thank you for that, Kelly and Mark, for your help last night. I would like to just leave us with one closing comment, I think, in the process. And that is something that, is a famous movie producer that we all know said, which is, I'm all for progress and innovation. It's change I don't like. From Woody Allen, thank you. So, ladies and gentlemen, I want to thank everybody for being here tonight, and let's come together and make some change in Hawaii. Thank you very much.